Get started, I'd like to welcome you to this kind of informal webinar presented by the Center for Transportation Studies in collaboration with the Translational Center for Resuscitative Trauma Care at the University of Minnesota Medical School. My name is Eric Lind, and I'll be one of the presenters today, walking you through some research we've been doing into transportation access to rural destinations. And today we're focused on trauma care in particular, especially thinking about trauma care in response to injuries and on the state highway network. Just a real quick brief word about the Center for Transportation Studies. We're a system-wide center for research into transportation, and we do everything from outreach and education to primary research and applied research with local and state and national government partners. We have a number of these webinars conducted on a lot of different topics. If you're interested in transportation at all, I'd encourage you to check that out at our event page. We have upcoming webinars in a couple weeks on pedestrian safety with respect to automated vehicles, and there's a focus this year on freight topics. So if those sound of interest to you, I encourage you to go look up our calendar page. So today, the way the Lunch and Learn is going to be structured is there's going to be a presentation by myself and Matthew Hockert, who's a research assistant with the group here. And we're going to be presenting some of our work, and then we are going to have a response from Lisa Rogers, who's the executive director of that translational center, and to think about how we might apply this research that we've been doing in practice. After that, we'll have some time for questions. Throughout, you can leave your questions in the Q&A box in the chat, and we can attempt to answer those as we get to them. And hopefully we'll be able to have a little bit of discussion at the end. Okay. So with that, I will start our presentation into the research. As I mentioned, my name is Eric Lind. I'm the director of the Accessibility Observatory, and I will hope to make that kind of unwieldy title a little bit more clear as we go forward here. And I'm joined by Matthew Hockert, who is graduate research assistant, PhD student in applied economics, and has been working with us for a couple of years now and has done the primary data work in this research. So we are transportation researchers, which I'll come back to, but what we think a lot about is how we should measure the transportation system in terms of how well it's functioning. As we think about how people currently do that, it's usually focused on network performance. That means people are interested in speed and delay and volume. So thinking about road segments, how fast are things moving? How many people are moving? How many vehicles are moving? It's actually really vehicle focused more than people focused. And the overriding goal of those types of network performance measures is to increase or maintain speed. Fastest is best. That's kind of the paradigm that most transportation evaluation is happening at. But there is an alternative way of looking at this, which might be called people performance. You can think about whether people could reach destinations that they need or want to reach. And a transportation system ultimately should be judged on how well origins and destinations are connected in ways that people can use. So to do that, we have some implications when we start thinking about things that way. Among them, it might be better to be closer, and it might not be better to go faster. It might be safer to go slower and still be able to reach your destination. And in fact, easiest rather than fastest might be best. So this concept of making it easy for people to reach their destinations is the definition of that kind of more unwieldy term accessibility. And for transportation researchers, one of the definitions of accessibility is the ease with which a traveler could reach valued destinations. So this is measuring ease as sort of an inverse of cost. And could, the other italicized word here is important because we're talking about measuring what opportunities people might be able to reach, not necessarily what they do. So the difference between observed travel behavior and accessibility in this sense is that accessibility is the universe of options available to people. But we can measure it, and that's what we do at the Accessibility Observatory. So we try to observe access or accessibility by measuring and mapping and analyzing where the opportunities are and how many they are. So for instance, with this map of the Twin Cities region, if you pick out a point in that map and imagine leaving that point at 8 a.m. on a typical weekday, traveling for half an hour to all the things you could reach, how many opportunities could you reach? And in this case, the opportunities are jobs. I'll talk more in a minute about the different types of destinations we can use. But this is giving a picture of a map of opportunity where higher or lower opportunity zones exist for people that start out or live in those areas. So this is a general method we use. Just to break it down for you, what we actually do, we are looking at origins, specific geographic places, destinations, specific geographic places, and we're thinking about choices. Okay. Choices are important because whatever your default mode of thinking about getting from origin to destination, not all of these choices are always available to everybody, especially thinking about automobiles, which might be your default mode. But driving a car is not available to people who are too young or too old or who can't afford a car. And this is certainly not restricted to urban geographies. Foreshadowing our look into rural areas a little bit. This is not only an urban problem. There are many people who cannot drive a car for many different reasons across the state of Minnesota. So we think about choices in terms of modes, and we also think about costs. And costs are part of that ease framework. How easy is it to get somewhere? You might think about having to spend time as one of your costs. You might be thinking about biking. There might be a cost associated with safety. You might be wondering, am I going to be safe as I travel down this route? Maybe I'll take a different one. That kind of imposes a cost on you. There's straightforward monetary costs, as I mentioned, with operating, insuring, fueling vehicles. And for walking and rolling, as it were, as a pedestrian, you could think about a whole different set of structures in the urban form or the built environment that might be important for you to consider as you think about your walk routing. So we try to account for these different costs when we're doing our access measurements, measuring how long it takes for someone to go from an origin to a destination. And really what we do is we calculate, again, all those travel times to all those destinations. We start out at a point at an origin, which is a census block. We use all the census blocks in the United States to do this. It's a big data project. And we route trips according to different modes and then add up all the things you can reach. And that is the basic element of accessibility that we then can parse, analyze, aggregate, and map. So before moving on, we have to think a little bit about the destinations that we map. We do a lot of mapping of job accessibility. That's one of the primary things for instance, our DOT partners are very interested in. But it's certainly not, the universe of things that's important to think about when you're talking about daily travel, reaching, your primary needs, your essential destinations. So we do measure travel times to education, to different healthcare, food, grocery, libraries, museums, social security offices, all kinds of different destinations. And today we're going to be focusing on trauma centers as a particular type of access in a particular way. The reason we're focusing on this is partly due to the theme of last year's research at CTS, which was Rural Needs Statewide Answers. There were many different projects that were focused on thinking about rural transportation in the state. And what we did was take our typical accessibility data and analyze it specifically thinking about the rural context. So we looked at access to high schools, for instance, by walking and by biking in different areas of the state. We looked at access to fresh grocery stores and food retailers across the state by different modes. And we looked at the project that Matthew's going to tell you about with respect to trauma care. These research summaries are available in a story map, which we can link to later on as well. But part of the purpose of this webinar is to kind of introduce this research that we've been doing and hope to generate some conversation about it. Just to set a little context in terms of Minnesota, when we're talking about rural areas, it's obviously a majority of the area of the state. When we're talking about the number of people, which is what we'd rather focus on, it's still a good share of the population of Minnesota, around 20%, over 1 million people living in areas that, according to this, USDA classification, could be considered rural. So certainly not the majority, but a huge population that we need to consider when we're talking about essential destinations and transportation. Okay, so now to focus on this particular destination of trauma care, I'm going to turn it over to Matthew to walk through what the questions were that we were working on and how he decided to attack them.
Thank you. Hi, everyone. I'm Matthew Hawkard. I am the graduate research assistant with the Accessibility Observatory. I will be, as Eric said, walking through our access calculations to trauma centers. What made this pretty interesting is that we kind of took the idea of access in a little bit of a different direction, in that we calculated access through a two-step approach. So you can see that here that in our first step, we are calculating the time it takes to get from an ambulance depot to a potential crash location. And then from those potential crash locations, the shortest time it takes to get to a trauma center. And so on the right, you see the state of Minnesota. All of these squiggly lines, these polygons, are different service areas. And what I'm going to walk through is, exactly how we calculate these things, calculate these travel times. And we'll look at one specifically in this next slide. So a specific service area, for example, is Sleepy Eye, Minnesota. Its service area is this black polygon outline here. And what we are essentially, this first step is just trying to calculate the average travel time from that ambulance depot in the center of that service area to each of the highway posts, which we are using as a stand-in for potential crash sites. So once we calculate each of these travel times from the depot to the highway post, we can average that and get an average travel time for this first step for Sleepy Eye, and then repeat that across other service areas and then across the state of Minnesota. So you can get these different travel times by service area across the state. So that's the first step. We are looking at the depot to the potential crash sites, but now we have to calculate the shortest travel time from each of those potential crash sites to a trauma center. And so in our analysis, we include levels 1, 2, and 3 trauma centers. We include levels 1 and 2 because they tend to treat severe injuries. But we also included level 3 trauma centers because, as we've heard, that they play an important role in stabilizing patients before they get transferred to maybe one of these level 1 or 2 trauma centers. So again, in this step, we are again just doing for every single potential crash site, each of these highway posts to their nearest trauma center. And then next slide, Eric. The beauty of doing this type of calculation is that we can then plot each stage separately. So that first stage, depot to highway marker, that is the average in that service area, and we can plot it across the state. So you can see like northern Minnesota here tends to have higher travel times, whereas southwestern Minnesota, those service areas tend to have some of the lower travel times to a potential crash site. And then the second stage here, that second step calculation, is those highway markers to the nearest trauma center. And each of these dots here are those highway posts that are the stand-in for the potential crash sites. You can see it's highly driven by population density or how close you are to a population center. Areas such as like northern Minnesota and out there in western Minnesota along the Minnesota River Valley there tend to have some of the highest travel times. So it takes quite a while to get from a highway post to the nearest trauma center in these areas, whereas in metro areas it may not. Next slide. And so once we have these two pictures, we have these calculations made, we can add them together to get that total accessibility. What this is showing is the total accessibility by ambulance service area. So you can see that there's quite a variety across rural areas here, but it's highly driven by our second step calculation, the highway posts to trauma centers. So areas in northern Minnesota, particularly in western Minnesota as well, tend to have really high travel times. Some depots may take over 2 hours to get to the nearest trauma center. Some other areas in central Minnesota and again in southwestern Minnesota tend to, in our data, not show such high travel times. Let me go to the next one. The last graph I like to show is just kind of flipping the previous map and looking at it in a little bit of a different way. So we have basically your access to service by travel time bin. Travel time is along that x-axis, and the number of services that an area may get within that travel time. We can see using a 60-minute threshold, something we've heard is kind of referring to that as the golden hour. The majority of service areas tend to be below that 60-minute threshold. However, when you just take one step over that 60-minute threshold and you move further along to the right of the x-axis here, it tends to depreciate quite quickly. So many areas still do not have great accessibility. And what this generally just kind of leads us to questioning is what are the solutions here? How can we hopefully provide greater ambulance services to these areas that are to the right of that 60-minute threshold? Thank you.
Thanks, Matthew, for that summary of the data. And so now I'm just going to reiterate that we were doing this as transportation researchers, kind of thinking about how we would look at this in an interesting way. But we are really happy that we have actual experts in trauma research who are here to help us. And so I'm going to turn things over to Lisa Rogers from the Translational Center to talk through what they make of this type of data and what else can be learned from it.
So I think that Matthew, pretty clearly defined that there is a concept we call the golden hour. In that 60-minute window, you have an optimal chance for survival if you get to a trauma center. However, one of the other situations besides time and distance, and of course weather, because we're Minnesotans, is the fact that we have several levels of providers in the state. And unfortunately, there is a mismatch between the most advanced providers and the travel time. So Matthew, can you pop up that map of Minnesota with the travel times really quickly? That's perfect. So in the pale urban and small urban areas, you typically will have paramedics who are capable of providing advanced life support, which I'll probably slip into and call ALS while I'm talking. These are the most advanced techniques. These people are highly trained. They've got lots of cool stuff on their rigs. In the areas that are veering towards purple and pink here with the long travel distances, your providers are either EMR, which is an emergency medical responder, which would be a law enforcement officer, a sheriff, a forest ranger, somebody who's got some basic first aid training, or an EMT, frequently a volunteer, who's only capable of providing assistance at the basic life support level. So CPR. And they're very limited in what they could do in terms of medication. And so this exacerbates the problem of travel distances, because you've now got your provider with the most limited scope of practice in your area of the greatest need due to transport time. And that's one of the things that I find really exciting about this data, is that it really reinforces what we have discovered. One of our residents, Julia Harrison, did a study looking at national data, not at just Minnesota, but looking at where does it matter if you've got advanced life support versus basic life support. And where that really matters is in a couple of populations. The over 50, we know that rural Minnesota tends to skew older than urban Minnesota, and in transport times greater than 1 hour. And so what we're really seeing is a mismatch. And some of the things that we do in our center is to begin to develop and evaluate ways to modulate that mismatch. For example, we have a project that we are hoping to get our final award letter from. We're told it's awarded to do tele-EMS in Southwest and Northeast Minnesota. And what that is it's just like any telehealth service. Your provider in the back of the rig calls in on a video, provides information back and forth to a physician or an advanced EMS provider. That allows them to make better decisions. It doesn't necessarily enhance their scope of practice, but it helps them make some critical decisions. And I think one of the critical decisions, and Matthew alluded to it, is the difference between level 1, 2, and level 3 trauma centers. And then I will throw community access hospitals in there. There's always this question of, I have a penetrating injury up here in the Northwest angle. I'm going to pick the worst case. And do I, as a provider, scoop and run to the nearest hospital of any kind to try and stabilize that patient? Or do I scoop and run to a level 3, 2, or 1 trauma center? Because of the virality of these areas, providers don't see a lot of cases. Those are tough decisions sometimes to make. A really great example I got from a provider down in Slayton, Minnesota, was somebody had touched a high voltage power line. And the person got up, he was walking around, he looked great, but she called into the tele EMS service and they said, check his cardiac rhythm. Because she doesn't see this kind of case very often, she had simply forgotten that she needed to do that. And so those are some of the things that we're trying to do to really improve EMS in rural Minnesota. And I think that I'm happy to answer any questions or provide any more detailed comments if someone would like.
Well, that's great, Lisa. Thank you for those examples. So we have a couple questions in the Q&A and a couple coming in on chat. So maybe I will take those, and I'm going to combine, there's two questions in the Q&A from Sandy that I'm going to kind of combine together and try to answer. But there's a side comment which is going to be asked again. So Sandy mentions there's level 4 trauma centers. So I'll put that aside for a minute. Can you also configure weather conditions, particularly winter? And then there are also variabilities relative to time of year and traffic changes with summer recreation cabins, different distributions of people. So let me answer that from the travel time perspective. We, for automobile travel, which is what we used for this estimation, we use observed speeds on each roadway segment by different times of day and time of year. So we're actually getting fairly realistic travel times on the road. We did not program a different travel time for an ambulance. So there may be, you know, this is not meant to be like a routing travel time prediction. It's more of just doing this as an analysis. But we do have fairly representative and accurate travel times on the roadway network for automobiles, because we do incorporate that kind of seasonality and especially traffic when we're doing our analysis. So that's the answer to the first question. Then as far as the second bit, and also we have a chat from Tim, why not include level 4 trauma hospitals? They're part of a networked into statewide trauma system and provide crucial early resuscitation, stabilization of trauma patients, and some provide surgical intervention if needed. Most of rural is serviced by level 4. I would love to have Lisa answer this, but before I ask you to do that, I'll just say we do have the travel times to the level 4 hospitals and to the community access hospitals, in fact, because we calculated the travel times as part of our basic research project to all of the facilities that are listed in the federal data set we were using. So we can go back and make those maps and do those calculations. We started with 1 and 2 because we knew those were the most important. We've sort of been hearing over time, maybe we should use a broader approach. So I'll leave that to Lisa as well.
So thank you, Tim. That's an important point. Yes, I think it would be really interesting and important to see how level 4 hospitals factor in, because as Tim points out, most of Minnesota is served by level 4 hospitals. And as Tim also put in the statute that talks about compromised airways, and many of those patients are going to go automatically to the nearest hospital, regardless of trauma level.
Thank you for that. Are there, this has been answered. Other questions that people in the audience would like to share, either in the chat or the Q&A, please feel free. And while we're waiting for that, the other point, transportation-wise, that I'll just raise is, of course, we do hear that these areas that we're focused on as having extremely long travel times are also where air ambulance support is typically used, or maybe used in some cases for kind of bridging that gap in terms of the over-the-road transportation. So Lisa, I don't know if you wanted to mention that at all. That's not something we've tackled, is air travel.
No, we actually have on a separate project doing some mapping for the air travel, because when I do my visual overlay of air travel, there are just a few areas that have gaps for that 60-minute air transport. And so I think sort of putting this all together, a colleague of mine has what he calls the Swiss cheese analogy for EMS. And Eric's nodding because I think he's heard us use this description before. EMS is multi-layered. And like Swiss cheese, there's holes in every layer. And as long as you aren't in an area that you've got a hole that goes straight through, you're in pretty good shape, unless, of course, things shift. But we have some areas in Minnesota, albeit with very low populations, that don't have coverage, period. Or we have some complex places like the Northwest Angle, which has very different situations depending on whether the lake's frozen or not. And so, you know, I think that's where it gets really interesting, is as we start to put all of the pieces of data that we have for this exceedingly complex system, to see where the holes are and the greatest needs are. And also, I want to say, to see where the successes are. You know, what rural communities are things really working well and clicking.
Thanks. So we have another question, which I'm going to give to Matthew, from Patricia. Patricia, in your slide with the areas where the golden hour is exceeded, have you overlaid that with the number of people in these areas? Did the height of the bars represent population size? I'll go back to that slide.
Eric, I don't think, I did not do that part of the analysis. I know for other research related to, the other research related to rural access, we had done some work with population. I don't recall doing anything related to actual population. And this chart that you're seeing here. It's definitely been talked about to do and to look at and see like how many people are like actually affected by certain travel times, added another dimensionality to the data. But if you recall something different, Eric.
No, you're right. I'll just point out
Okay.
what these are the service areas. So this is the count of the service areas that have to travel on average between 90 and 100 minutes. There are 5 of those. So that corresponds to these polygons, sort of like where those total travel times are. But the other reason we're not focused on population is because this is because we're anchoring this to the roadway network in particular and thinking about crashes in particular. They're not as associated with like residential population. It's kind of just thinking about it as a place. And really what this map on the right is a map of one component of risk when you have a crash at these locations. So there are lots of other, engineering and other personal factors of risk. This is the post-crash care transportation piece of that risk, that we do hope, others can think about it that way too, if they're thinking about a total, risk model, that this piece of it would be attached to the place where a potential crash happens.
Can I jump in and ask Chris Colling to clarify? Her comment is that as a trauma surgeon at the Level 1 Center in Duluth, this is an issue that I'm faced with every day, and we've done some work with Chris. It's been really enlightening. She asked about like what actual data is needed about how hard it is to get to patients to our hospitals. Chris, would you type in if this is sufficient data, or if you would like to think about even additional data that would help with that question that you have?
And actually, Chris, I'm going to go ahead and let you talk. So if you want to unmute, you should be able to do that.
Oh God, I wasn't prepared for that.
You can blame me, Chris.
That's okay. I'm happy to. I'm one of the trauma surgeons at St. Mary's, and feel really lucky to be able to work with Lisa and Greg on the trauma research for this, because I think it's something that is really important. Because just because you live somewhere rural doesn't mean you should have, less access to being able to be treated for trauma care. I think like, honestly, I think this is such even just a important highlight of how hard it is to even like how long it takes to physically get people to the trauma centers it's long up here. You can kind of see that, anyone that lives in northern Minnesota, it is tough to get to a level 1 or level 2 trauma center. And again, yes, they don't have to necessarily come to me to get good care, but for definitive care, they for sure do, right? For most things, like if you're super injured. I think one of the things that we get up against is even when people are seen at a level 3, 4, or a critical access hospital, even the difficulty of getting them from there to our hospital is very difficult. Just because there are not, like, this is my second comment, there aren't enough critical access or critical care, ground transport ambulances. So up in International Falls, so one of the furthest places that comes to us, they have 2 ambulances for their entire county. So if they're driving someone from me or from their hospital to me, I think it's a 2-hour drive. I should have my map, but I don't know exactly what it is. So that, and that takes that ambulance from their community for that 2+ or 4 hours, I guess, because they got to get back. That I think that would be kind of an interesting addition to look at for equity and access, and like your ease of access idea is like, when we take those transfers, like how are we affecting the community, and could there be better ways that maybe that could be addressed, whether that's having ambulances come from my hospital, which I think would be an interesting way, and go pick them up, or air ambulance, but that's another, 1 cost, 2 risk. It's all really complicated. I don't know if that answered anyone's question or if I just raised a button.
No, it was great to have your perspective, and I think one of the things I heard was also, and I'm seeing in the chat, is there's we're not raising like new issues. We're sort of documenting maybe in detail that might be helpful, issues that everyone kind of already knows, and we just want to make this available for however you're going to use it, even if it's for making those arguments about maybe changing the distribution of those, those critical care transports, whatever it might be.
And that's kind of what I think this research is so important for, is it's identifying the problem, right? If no one's looking at what the problems are and saying, hey, there is a problem, like you can't physically get these people here. And if you don't know that, then there's no way to address it. So I think that's what I think the TCRTC and everybody working on this stuff is doing such an important thing of just first identifying even what those problems are, so we can start doing things about it.
Thanks for hopping on. Appreciate that. I just want to note a couple of links that were shared in the chat. One on the current drive time map that's available from the State Department of Health on trauma care. So just looking at that really quickly, yeah, it looks pretty related, although maybe a little bit more general than this type of analysis. And it would be great, Tim, to be connected with people inside the Department of Health that are working on this as well. And then Sandy shared an ambulance deserts study, which of course is a really an accessibility analysis that people have done with a lot of different destination types. And, you know, we're working on in a separate project on pharmacy deserts. Many people have done grocery deserts. So yeah, the ambulance deserts is an interesting way of thinking about this as well. And maybe, yeah, maybe something to build on. So with that, we're about at 12:45, which is about the amount of time we wanted to spend thinking about this. I want to, before we conclude, want to give Lisa a chance to make any sort of concluding comments that you have, or any other reflections or things you think we should be tackling next with this.
Aside from my comment that I would love to see the data from the level 4 hospitals, I think this is really great data to have as we explore all of the, as I said, the many factors that go into an effective EMS system. And I really appreciate the level of detail, and I will say the very beautiful maps that Matthew has created. And certainly, if folks on this call are interested in having more conversations, reach out to me, reach out to Greg, and we'll be happy to have more conversations.
That sounds great. I should have noted in the beginning that we're originally planned to be joined by Greg Bielman, who's the director at the Translational Center, and unfortunately couldn't be here due to a personal conflict today. But yeah, he's been very enthusiastic about this data as well. So it's been great to have this partnership beginning, and just thinking about the different ways our centers can work together. So thank you so much, Lisa, for being here today. Also want to thank Matthew for all the hard work and for presenting. And I'm putting the link in the chat to the story map, which contains some of those beautiful maps and also a little bit of narrative around this project, including some other topics on, as I mentioned, grocery access and high schools, which we might try to tackle in a later Lunch and Learn. So with that, I want to thank everybody for attending and for your questions, and look forward to seeing you again. Bye for now.
Thank you all.